conflicting messages every second day. The HSE issue once set of instructions, it's then contradicted by the SDU the next day. So tell me who's running the health services, the SDU versus the HSE. Secondly, your title is Special Delivery Unit. When are you going to deliver anything to the acute hospital sector? Because we were visited by the SDU, as were many other hospitals in this country. We outlined all our issues. We got agreement from the SDU that our problems were real, they needed to be escalated, they would be brought back to the Minister, there would be a priority based on the issues that we identified. We haven't heard a single thing, and that's 6 months later. Since then, we've been visited by a number of different groups of the Department of Health. We're still where we were 6 months ago. So if you're going to stand up there and give us a talk on delivery, you need to be seen to deliver. And thirdly, I'm horrified to see that you're back with red, amber and green. We had this from the HSE already. It didn't work. All the hospitals were scored on red, amber and green before. All it did was identify hospitals that had a lot of resources which could meet targets, and it criticised hospitals who had no resources and couldn't meet targets. That did not work before, it won't work again. So just to recap, who's running the health service? The SDU or the HSE? And hospitals that the SDU already agree have issues that need to be addressed. When are you going to do that?
I'm very pleased to hear that there are additional beds going into Our Lady of Lourdes Hospital, because we've been in major crisis for the last number of years, so I'm very pleased to hear that. But as a public health nurse, I'd like to know when these patients are discharged from the hospital out into community, our resources are horrendous and we're on our hands and knees, and now we're getting additional patients home who are not always in the best condition for being discharged. So the question I'd ask is, if you're putting money into the acute services, when are you going to put the money into community to support the discharge of these patients?
Specifically, we support very much primary care. We do believe that the place for the patient, if at all possible, is in their own home, in the community. We care for the staff who are there. But if you take the HSE figures, 1,700 public health nurses were working last year. We're down now to 1,412. And if the PHN course goes ahead, it's going to be 40 this year. So I suppose my question is, how can we continue to give safe care to the people where they need it in the community, which is what you want and what I want and what my colleagues want. We can't provide services if we don't have the people on the front line, on the ground, to meet the needs of the clients. And this against the background where the HSE has said they want to reduce the agency staff by 50% this coming year. And at the moment in the community, it's the agency staff that are enabling us to provide service to the people in their own homes. Finally, what I want to say is, people are into all data. There are many a new person who I've gone to see over the years who've put their hand in mines and thanking us for everything. So it's not just a flow of data. These are real people that just some who don't have families or other carers, and we're the only people that goes into the front door. So thank you.
Very much for your very good presentation, and I very much welcome anything that assists patients and safe practice and safe care and quality care. So I welcome the introduction of the special delivery unit. But I suppose in reality, the thing is that we have thousands of patients on trolleys in the ED departments every year. It's completely and utterly unacceptable. One patient on a trolley too long is one patient too many. We have turned the emergency departments into wards, and it's just completely unacceptable, and it doesn't permit us as registered nurses and midwives to deliver the care that we are trained to deliver. That's the first thing. Secondly, since the introduction of the special delivery unit, we're all speeding up, speeding up, speeding up. We just cannot continue with the speed at which we have to deliver the care, because the average length of stay now has gone down. But unfortunately, the thing is that what we have noticed is that it has now created a revolving door. So unfortunately, although some patients are going home in time and appropriately, other patients really are being rushed through the system so that we reduce the number of patients on trolleys in the emergency departments, and it makes the figure look good. The other point about that is that these patients are being readmitted much too often, and then what happens is the figures that we have at the moment, which are improved on last year, 17%, whatever it is, the fact of the matter is that this is a false, not all of it is correct, because as we said earlier, there are patients on trolleys up the wards, on corridors, on extra patients on wards. And really and truly, the whole thing is not about, as Joe and everybody else said there, this isn't just about, or shouldn't be just about, ticking boxes, green, yellow and red. This is about patients, it's about safe care, it's about nursing care, and it's all about us and what we can deliver for the patient. Patients are only admitted into the acute service if they're very, very ill, but they are most certainly being discharged early, some of them, into primary care where we don't have adequate public health nurses and we don't have adequate nursing staff and midwives. So I suppose why I welcome the special delivery unit, we cannot get away from the fact that it's patients we're talking about, it's human beings we're talking about, they're very, very ill, and we cannot get away from that fact. So, I mean, it is about safe practice, safe care, and there will be no compromise. And thank you.
I absolutely agree with what you say. The issue is not about one of reducing patient experience to mere statistics. Neither is it about suggesting that the impact of full capacity protocols, which are in place pretty regularly in many hospitals, is the ultimate improvement. It's not. And we're very clear that what we need to do is move to a system which is focused on patient experience time, not just numbers at a point in time, and which matches resources with demand, not just in emergency departments, but elsewhere in the hospital, and in conjunction with programs like the emergency medicine program and the acute medicine program, balances the way resources are used up the house, to use Liam's term, which is a term we use quite a lot, I think. In relation to the question asked by Joe, it's true that at the moment our focus is very much on acute services, and our brief as a special delivery unit does not extend to community services. I'll come back to that in a second. The use of RAG systems, red, amber, green. In the past, there have been use of such systems in the service, particularly health stat. And the concern I would have about that, which may not be the same concern that you're expressing there, is the problem it was arbitrary. It treated all facilities as though they were starting in the same place and going to the same place. And in addition to that, it gave a number of services green ratings for relatively poor performance. The RAG rules, or the RAG system that we're seeking to implement, is one that is tailored to the individual, in this case, hospital situation, that looks realistically at the starting point, the challenges they have, and focuses on a particular trajectory for improvement, which takes account of the different resources, the different demands they have, and around the way we work with them to bring about those improvements. So it's not the same as the RAG system that was in place before, but it is one that was used very successfully in other systems that have travelled the journey that we're now trying to travel. In regard to the comments that you made about the interaction you've had with the SDU, I don't know the details of that, but I'd be happy to talk to you and see what has or hasn't worked well in terms of the way the SDU has interacted with that hospital or another. In general, I can say that we've delivered in a very targeted way quite significant resources to deal with very particular issues in a number of hospitals across the system, not in every hospital. And maybe there's something we need to do differently. I'm not clear. I'll find out which hospital. I'll see if I can make contact with you to talk about that. In relation to the community, it is clear, and this is part of the clinical programs led by Barry White as well, that if we are successful, as we should be, in moving some elements of care outside of acute hospitals into the community, then the resources must go with that. In the area of discharge, and there was a specific question about facilities for patients being discharged, one of the things we will be commencing very shortly is the allocation of some 30 million euros, which has come some from the NTPF, some from the Fair Deal scheme, to enable assisted discharge, to enable rehabilitation for patients who would otherwise spend up to 10 weeks in acute hospitals waiting for the processing of their paperwork for Fair Deal, in the meantime becoming much more likely to only be able to avail of long-term care, when if the interventions were more quick, more speedy and more accessible, they may be able to return to their homes, which is where they prefer to be. And that will allocate resources, probably not enough in one go, but in the direction that some of your questions have been going on. We don't have the remit for primary care, at least not at the present time, and so I don't want to go too much into that. One of the quality scores which balances the access score is around readmission. Clearly, we're very conscious that if we're seen to drive like a bull at a gate at the access target without balancing that with quality targets, then we are capable of producing unintended negative outcomes. So on the scorecard, very clearly is readmission within 28 days. And there are evidence-based targets that will be measured against that, and where hospitals are producing outcomes which aren't in line with that, we'll know that it's necessary to look at least to see whether they're doing things to achieve the access targets which are contrary to patient care requirements. So there is a genuine effort on our part to balance these things, and that includes on the resource side as well. Whether we are comfortable with it or not, the health service does have to live within a finite resources, and the way we use those will determine how good a quality of service we provide to our patients, what the environment is for our staff, and whether we simply carry forward accumulated problems into subsequent years. So I didn't come here today in any sense to suggest that we have done our job. We have not. We have just begun. And I welcome the feedback, and through your elected officials and your other officials, I'm sure that we'll continue to receive it. So thank you very much.
Thank you for that delivery of what you're doing. I concur, and I can't put better than what my previous speaker has just said about continuing care in the community and how to do this. But what my main question is, as the nurses and the INMO has been highlighting the problems and child with torches, you said, in all the corners and the trolley weights and the trolley queues, and the nurses are now showing me that this is in fact the way we should have been going all the time. Have you considered, the Department of Health, have you considered employing nurses to help you with this problem? You have unemployed and underemployed nurses. You have nurses with experience. Nurses who could run A&Es with an eye touch in one hand and a prescribing pad for x-rays or medication in the other. And the patient would only have to tell their story once, and they could be then routed or sent in the right direction, whether it was to an acute setting or a home care package. And finally, we hear a lot about value for money. You know, there is no better value for money than a nurse.
I think the best thing I can say is that I hear you. We will continue active engagement with the INMO. In the few short months we've been around, we've made a conscious effort to liaise directly with your officials, and we'll continue to do so and take your suggestions on board. The specific issues you've raised essentially around the issue of hospital avoidance are key issues that we're currently examining, and also the issue of ensuring that there is appropriate first contact on arrival at an emergency department is a key one as well. I don't have immediate answers for you, but they are things that we're currently considering. Thank you.
Thank you.